So this presentation is on perioperative anticoagulation management, and the reason why I did this presentation was because I think this is a very important topic that both surgeons as well as those in medicine who do gastroscopies or colonoscopies would find it very useful, because you don't know if you're going to take off the aspirin, do you take off the clopidogrel, what about the heparin, do you learn molecular weight heparin or unfractionated heparin? So I did this presentation in the hope to clarify things for you, and I also want to disclose that this is based on, this may vary depending on which country you are in, so just check with the protocols in your hospital. But the general idea is demonstrated in this slide. So perioperative anticoagulation is difficult because you need to balance the risk of hemorrhage with the risk of thromboembolism versus the risk from surgery versus a benefit from surgery. It's very easy if the patient has a cancer or they have limb-threatening diseases, and so the surgery wins, irrespective of the risk of hemorrhage or thromboembolism. However, if they're undergoing hernia repair or elective non-urgent operations, you really need to balance this. Like, is it worth it that the patient undergoes a hernia operation if they might develop a stroke? So it's very important to have an individualized treatment, and this slide would go through how we do that. So you also always want to assess the patient 7 days before surgery for planning of perioperative anticoagulation management. And you must provide the patient with written instructions so that they remember and you remember as well. And INR testing must occur on the day before the surgery. The patient is at low risk of thromboembolism if they have had a venous thromboembolism, for example, with deep vein thrombosis more than 3 months prior. If they have atrial fibrillation and their CHADS 2 score is 2 or less. If they have cardiovascular or cerebrovascular disease, they're still in the low risk. And if they have a low risk prosthetic heart valve, for example, a bioprosthetic like a pig valve or a newer model mechanical heart valve. They become at moderate risk of thromboembolism if they have atrial fibrillation and their CHAD score is 3 or more, or they also have valvular heart disease. If they've had arterial or venous thromboembolism within the last 1 to 3 months before the date of surgery, or if they've had these thromboembolisms recurrent or they have thrombophilia, they're put into the moderate risk. Any other cardiac valves, such as the older models of the mechanical valves, would be putting the patient in the moderate risk of thromboembolism, and multiple strokes, TIAs, coronary artery stents. High risk of thromboembolism. If they've had an arterial or venous thromboembolism within 1 month of the proposed surgery, so they've had a stroke or they've had a DVT or a PE, they're at high risk of also getting another one. So CHADS 2 score for non-valvular atrial fibrillation, it's based on these 4 categories. So C stands for congestive heart failure, past or current, they get 1 point. Hypertension, they get 1 point. Age greater than 75 years, diabetes, and stroke, TIA, or thromboembolism, they get 2 points. So this is double the risk of these other factors. So antiplatelet therapy can be either divided into therapeutic or prophylactic doses. So therapeutic antiplatelets are for those with recurrent strokes or TIAs. They've had recent myocardial infarcts or coronary artery bypass graft. They've had a bare metal coronary stent within the last 4 months, a drug-eluting stent within the last 12 months, and atrial fibrillation with a CHAD score greater than 3 or greater. And prophylactic antiplatelets are for those with other indications. So the bleeding risk of surgery can be divided into high and moderate, low and very low. So here we can see that those who are undergoing radical pelvic or abdominal surgeries, breast surgeries, or a history of bleeding or coagulopathy are at a very high risk of bleeding. Low risk is abdominal wall surgery and non-radical pelvic surgery, and very low risk are your hysteroscopies, cystoscopies, endoscopies. So here's a table that demonstrates that you need to balance the bleeding risk here and the thromboembolism risk. And just by looking at this table, it's clear that if the patient is undergoing an operation that has very low bleeding risk, you just keep them on their usual treatment, because there's no point of taking them off their medications if they're not even really at any risk of bleeding. However, if the bleeding risk is between low, high, and moderate, it's interesting to see that thromboembolism risk kind of places a more greater weight. So if they have a low risk of developing a thromboembolism, you kind of manage them in a similar way, irrespective of how much bleeding there will be in the surgery. If they have moderate thromboembolism, they have a similar way of managing before surgery, as well as high. But the high one is quite different, because if they have a high thromboembolism risk but the surgery is a low bleeding risk, you kind of manage it the same as a moderate thromboembolism. But if they're at high risk of both thromboembolism and bleeding risk because of the operation, there is a different protocol. So the third protocol, which we'll go through soon, to manage these. And it's interestingly, anti-platelets have a different protocol overall, and new oral anticoagulants, and just reinforcing that if the operation has very low risk of bleeding, you don't really need to think about any of this at all. So we're going to start with when they have low thromboembolism risk, work up this, and then go down to antiplatelets and NOACs. So this is for those with low thromboembolic risks and irrespective of the bleeding risk, low to high bleeding risk of the operation. So you want to cease the warfarin 5 days before the surgery. You want to check the INR 1 day preoperatively, and if the INR is greater than 1.5, give them vitamin K 2 milligrams orally to try and get that INR back down to 1, and recheck the INR on the day of the surgery. Once they finish the surgery, you recommence them on prophylactic doses of low molecular weight heparin, and recommence at warfarin as soon as possible. Once you reach an INR of greater than 1.8, you can cease the low molecular weight heparin. So that's really just the bridging. If they have a high thromboembolic risk but undergoing a low bleeding risk procedure, or they have a moderate thromboembolic risk, and it doesn't really matter how much bleeding risk there is in the surgery if it's low to high, you want to stop the warfarin 5 days before, and then you need to bridge them with heparin. So you want to commence therapeutic doses of low molecular weight heparin 2 days preoperatively. Administer the last dose of low molecular weight heparin 24 hours before the operation. Check the INR at this time, and if it's above 1.5, give them vitamin K 2 grams orally to bring it down to 1, and check the INR on the day of the surgery. Then after the surgery, you commence prophylactic low molecular weight within 24 hours and increase the dose to therapeutic low molecular weight within 24 to 48 hours. And then you recommence the warfarin at the same time. You start the first dose of the heparin, and you cease the low molecular heparin when INR is greater than 1.8. And so the red kind of indicates the differences between the previous management plan. So previously you would start them off with, so here it's like prophylactic. Here they start with prophylactic, but then it jumps up to therapeutic doses because they really need quite high doses of heparin because they are at a higher risk of thromboembolism, and they need the bridging as well. And so this one is when the patient has both a high risk of thromboembolism, but what they're undergoing has a very high bleeding risk. So you would consider in these patients putting an IVC filter less than 4 weeks before the surgery if they've had a DVT and a PE. You want to cease the warfarin 5 days again, admit into the surgery for IV adjusted dose unfractionated heparin 2 days before the surgery, maintain therapeutic APTTs, and cease IV heparin, unfractionated heparin 4 hours post-op. And the reason for this bridging by using unfractionated heparin is because you're able to have a closer eye on the patient's anticoagulation, and because they're at such a high risk of thrombosis, you're able to keep the warfarin all the way up to 4 hours post-op compared to the previous one where you had to stop at 24 hours before. And then you have the surgery, and then you recommence IV heparin without the loading dose at the previous therapeutic rate, and then consider changing to therapeutic doses of low molecular weight, and cease the unfractionated heparin 4 to 6 hours before the first dose. And you recommence warfarin as soon as possible and cease when the INR is greater than 2 rather than 1.8 before. If the patient is on anti-platelets, there are 2 ways you can manage these patients. You either just cease all of the antiplatelets 7 to 10 days before surgery because it has such a long life, which includes aspirin, clopidogrel, ticlopidine, and diapyramidol. The alternative is to continue aspirin and cease all the other ones. And the reason for this are especially for patients who have a drug-eluting coronary stent, who are at risk of increased stent occlusion in the first 6 to 12 months following insertion. In these patients, the clopidogrel should be ceased 10 days pre-op, but the aspirin should continue. And when they mean by drug-eluting coronary stents, these aren't eluting to stop thrombosis. They're stopping the formation of atherosclerosis within the stent, within the coronary artery. In terms of NOACs, and in a semi-acute / elective surgery, you want to assess the risk of bleeding against the risk of thrombosis, as these agents may not need to be discontinued for minor procedures. You would only consider bridging anticoagulant therapy like heparin if there is a high risk of thrombosis. In situations where complete hemostasis is required, APTT and TT should be checked preoperatively. So the timing of discontinuation should be based on the following chart. So here we have renal function, and here we can see the timing of discontinuation before surgery. And it depends on whether the surgery has a high risk of bleeding or a standard risk of bleeding. So if it has a standard risk of bleeding and the patient has normal renal function, you stop it 24 hours beforehand. If the patient has terrible kidney function, you want to stop it 2 to 5 days beforehand. But if the operation has a very high risk of bleeding, you would try and double or even quadruple the date before removing the NOAC. In emergency surgery, a NOACs is very difficult to manage because there is no test that really shows how much anticoagulation the patient is undergoing, because INR is not an indication of bleeding risk for these patients. So the standard tests of APTT and prothrombin time, that the drug is present at very low residual concentration, ensuring that emergency surgery can be performed without further delay and without a significant increase in bleeding risk. So, in summary, if you have a patient who needs to undergo emergency surgery and they're on a NOAC, check their APTT and prothrombin time, and kind of trust that a bit more than your INR. Just some precautions with low molecular weight heparin. It is renally excreted, so for renally impaired patients, you need to modify the dose and monitor the anti-10A levels if their weight is over 150 kilos. If the patient has had a history of heparin-induced thrombocytopenia with low molecular heparin, they shouldn't get low molecular weight heparin again. And for those who have a history of bleeding disorders, intracranial hemorrhage, GIT bleeding, recent trauma surgery, severe liver disease, just think about whether it's safe for them to be on this before starting it, because they could bleed again and lead to serious complications. I'm just outlining the differences in dosages between prophylactic versus therapeutic low molecular weight heparin. Usually the two are enoxaparin and dalteparin, and the doses prophylactically are 20 to 40 milligrams subcut daily. Therapeutic doses of enoxaparin is 1 milligram per kilogram, subcut twice daily. And so if you think about it, they're 70 kilos. So you got to give 70 milligrams, and that's almost double. And that's the same with dalteparin. The therapeutic doses are double the prophylactic doses. So here is a summary in color of how you would try and manage the different risks of bleeding versus thrombosis in different patients. This protocol obviously changes with different hospitals, and I would recommend you to just double check with your hospitals what they recommend, because that's how you should practice. But I hope that I've clarified some things for everyone, and I hope it was useful. Please let me know in the comments below